Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adebuya. In this episode, I will be chatting with Dr. Sanjiv Narayan and Paul Wang. Dr. Narayan is a professor of medicine, the director of the Stanford Computational Medicine in the Heart Integrated Program, and co-founder of the Stanford Arrhythmia Center. He directs the Computational Arrhythmia Research Lab, which operates at the intersection of cardiovascular medicine, bioengineering, and data science. He earned his MD in neuroscience from the University of Birmingham and completed his residency at Cambridge, Massachusetts, and his cardiology fellowships at Washington University in St. Louis. Dr. Narayan is the recipient of the Distinguished Scientist Award of the Heart Rhythm Society and the Top Doctor Award from Castle Connolly, among others. Dr. Paul Wang is the director of the Stanford Cardiac Arrhythmia Service and professor of medicine and bioengineering. He is an expert in the treatment of cardiac arrhythmias, including atrial fibrillation, atrial flutter, ventricular and supraventricular arrhythmias, and sudden cardiac death. He was a co-inventor of catheter cryoablation, which has been used to treat over 1 million patients with atrial fibrillation and has pioneered new techniques in the management of heart rhythm problems. He earned his medical degree from Columbia University, completed his residency at New York Presbyterian Medical Center, and his cardiovascular and cardio-electrophysiology fellowship at Brigham and Women's Hospital. Thank you both for chatting with me today.
It's really a pleasure to be here.
Great to be here. Thank you.
I'm thrilled to have the chance to speak with both of you about electrophysiology, arrhythmias, and the incredible advancements happening in this field. To start, I'd love to hear about your journey as clinicians. What inspired you to specialize in electrophysiology, and how has this focus shaped your clinical practice? Dr. Narayan?
I really love what I do. I think we all do, everyone here at Stanford and in the profession. For me, the heart just seems such an incredibly intricate organ. At one level, it's just a pump. On the other level, it causes so many problems. And of course, at the other level, it's so essential to health. I was fascinated by it, how something so simple can be so critical and yet could cause problems in so many people. I also was fascinated because at some level, it seemed pretty simple to me. That's what led to my fascination with the research. It's incredible how something like the ECG, which has been around for 120 years, can still be giving us insights. Of course, we don't just stick with the body surface ECG, we do it inside the heart, but it's fascinating how we can understand complex rhythms, atrial fibrillation, ventricular tachycardia and fibrillation, and treat them based on looking essentially at just those ECGs.
Turning to you, Dr. Wang.
I was attracted to cardiology because I viewed it as a mainstream problem that many people have. We view it as a potentially serious condition where you're thinking, oh, this might have big impact on their life. I decided when I started medical school, how can I approach this? I looked for mentors in cardiology, and it happened to be the first mentor that I found was a specialist in cardiac arrhythmias. I always tell my students that could happen to you. It's often self-fulfilling. What you end up thinking you want to do, you have a great experience, and then that's something that gets your attention and continues as part of your career.
I enjoyed hearing the pivotal role that your mentor played in shaping your career. It highlights just how important mentorship is in setting students up for success and helping them discover and develop their own passions. Dr. Narayan, to kick off our conversation on arrhythmias, could you talk about some of the most common electrical abnormalities that you encounter in your practice and how they typically present in patients?
There's a broad spectrum. Some people see us because a skip beat was picked up in ECG and they didn't feel it. Other people have arrhythmias diagnosed because they present with a variety of things across the gamut of medicine. Feeling tired, feeling a bit lightheaded when they stand up, which of course could be normal, but could also be the beginnings of bradycardia, for instance. The arrhythmias we see could span many of those. This gets into the exquisiteness of it, that you've got simple things like premature atrial beats. They can make you feel pretty lousy, but they're benign and they're easy to treat. all the way through to atrial fibrillation, which can cause problems like stroke, fatigue, hospitalization, even heart failure, even worse in the most extreme cases. Yet often is not picked up early and people go undiagnosed. It's this breadth that makes it so fascinating to me. We don't understand much of what causes those differences in presentations between people. We just don't know why.
Thank you for highlighting the complexity and the nuance in diagnosing and managing arrhythmias and how the same underlying issue can manifest so differently across patients, from something as benign as premature atrial beat to something that is really potentially life-altering and a consequence of atrial fibrillation. As a follow-up, could you discuss how early detection impacts patient outcomes and the potential long-term risks of untreated electrical abnormalities?
We live our lives with billions of heartbeats, and the heart is an incredible organ. Occasional abnormalities are not a problem. We all have an occasional skip beat when we're doing our SATs or running a marathon. But of course, early detection is good. Without being paranoid, a simple measure is check your pulse. The same way you check your weight, you check your blood pressure, people could just check their pulse. People then get used to the idea of regular versus irregular. Moving forwards beyond that, many people are wearing wearables. It's an increasing part of our daily lives all over the world. And this is a phenomenal tool for cardiology and heart rhythm. You don't really know what symptoms people have, and people may not have symptoms. But on the other hand, Apple Watch and other devices are easily available. So early detection is great. Without getting alarmist, I think it's just good for us to build into our daily lives, teaching our patients that's worth doing. If one sees an irregular rhythm, then kick that up to the next notch. Speak to your family care provider, speak to someone in the team. We're always available in the arrhythmia service to help.
Dr. Wang, building on that, can you discuss the key risk factors and triggers for arrhythmias that clinicians should be aware of in their patient populations?
I tend to think about triggers and then different factors that may contribute to the disease process, acquired diseases, our aging process, other things about our overall health. Arrhythmias often are manifest by things that can lead to symptoms like palpitations that patients actually feel. They're the signal that something is going to happen. That's not true of many of the problems we have. Many of the medical conditions we don't feel until a very late stage, whereas arrhythmias you could feel from the very beginning. Similarly, they're pretty straightforward to diagnose. We don't need any fancy kind of machine. It's called an electrocardiogram. These patients identify themselves, what might cause it, lifestyle, various comorbidities, diabetes, hypertension, and other things related to aging. The same things that we counsel our patients about, specifically for arrhythmias, are often those same things we tell people for getting good health and good cardiovascular overall condition and lifestyle. The other things we talk about is more triggers. Patients will always ask me, is there anything I'm doing that might be resulting in these arrhythmias? We go through this list that's pretty standard of common triggers like caffeine, physical, emotional stress, physical exhaustion, systemic, metabolic problems, dehydration, sleep disorders. There's so many things that overlap that affect the heart, in particular heart rhythms. Patients also often come with the information themselves. Oh, when I do certain kinds of activities, it actually will result in it. But we generally don't tell people, oh, don't exert yourself or do certain things unless we can identify pretty clearly. There are some situations that are more medical, such as an operation, a colonoscopy, a colon prep, things like that. They can be pretty common triggers. So they'll get post-operative arrhythmias. There are many different possible triggers.
What I'm hearing you say is that arrhythmias can act as both a signal of broader health issues and a condition influenced by such a diverse range of triggers, from lifestyle factors to specific medical events. Given this complexity and variability, how does this breadth of factors influence how you, as a clinician, manage the diagnostic process?
It has many great ramifications. One, sometimes it'll lead patients to us. They may have symptoms that are pretty general, that is shortness of breath or fatigue. Sometimes I think we miss the diagnosis. No one thought it's an arrhythmia. They went off and looked for other causes. The opposite can happen. Someone can be referred because, oh, I think it must be an arrhythmia. In actuality, they have a totally another problem. I had a patient got referred for exactly this, shortness of breath and anemia and fatigue. Turned out they had colon cancer and they really were anemic. What's great about arrhythmia is that as long as we can catch the episode happening, we can pretty reliably and very safely make the diagnosis in interpreting, as you said, these variety of different symptoms that people can have. One of the first messages is symptom awareness. We do encourage patients to bring forward their symptoms. And then it's on us to make the diagnosis, is it arrhythmic or not arrhythmic? And simply, as long as we can capture it, the challenge is that when we can't capture it because they're so transient and maybe even infrequent, that can be the difficulty. And that can be very frustrating for patients. We do have other strategies. It's something very specific called an implantable recorder, loop recorder. That allows for situations like, oh, I have severe symptoms, but they only occur 3 times a year. With a 2-week monitor, we're going to be generally pretty unsuccessful. But if one wants to really capture it, that's something we very much might want to do, is to implant such a monitor.
There has been an increase in arrhythmia diagnoses in recent years. In your experience, what factors are contributing to this trend, and how should clinicians respond?
We are seeing many more arrhythmias. It's increasing rapidly. Part of it's recognition, which we're very pleased about. It means that patients are more aware. And we as clinicians also are much more aware because we see so much of arrhythmia. Finally, the disease processes are increasing. We all accept that we're in an aging population. Most of the acquired arrhythmias are increasing with age. And the other associated factors, metabolic syndrome, diabetes, hypertension, they get more prevalent with age also. And perhaps other factors such as obesity increasing, et cetera, they may be also contributing to our increased awareness and frequency of these arrhythmias. We're seeing truly an explosion in arrhythmia.
Dr. Narayan, you mentioned wearables earlier in our conversation. I'm curious about your thoughts on wearables and how they've become such an integral part of our lives. Are you noticing a trend where self-diagnosis of arrhythmias has increased because people are constantly tracking their activity with devices? Are you seeing more patients with benign conditions as a result of this increased monitoring?
We have people self-diagnosing. I actually think the ideal would be we have full disclosure all the time. If you're the kind of person that doesn't want to know, switch it off. If you do want to know, fine. It's up to us to then sort out what's real from what isn't. It's one of the fascinating areas that arrhythmias, electrophysiology is so well suited to autosensors, artificial intelligence, computer models, that over time is beginning to help us sort out what is important from what can be just reassured. We're not there yet. There's still a lot of false positives, but I don't think it's bad. I think it is better to have full disclosure and then sort it out later.
One of the great things is that as those devices become more prevalent, I think that'll be available for more people. It's fundamentally a consumer product, yet there are abilities to help us make the diagnosis of arrhythmia. Yes, I think we're all a bit fearful that we'll be deluged, but we think of that as an important step for healthcare, et cetera, because we do think of it as a way that people with previously undiagnosed arrhythmias might be detected in a very kind of comfortable, safe way for patients. As a society, we have trouble screening people for any condition, and just the healthcare costs and the need for education and dissemination can be very daunting. But if the public becomes more aware and have these accessible, then it allows us this entree. We're excited about the promise that people with undiagnosed arrhythmias might be able to be diagnosed in an earlier stage.
That's such an excellent way to frame it, as a supportive tool that empowers patients to take greater control of their health and become more aware of their well-being. Ideally, of course, it also helps streamline the screening process, making it more accessible and effective. Dr. Wang, what are the current best practices for managing patients with irregular heart rhythms?
It's the subclassification. What is exactly the arrhythmia, what treatment is required, and why? Sometimes it's going to be treatment for symptoms. The other situation is, are the arrhythmias signal for something more serious? That's at the forefront of our minds. That does tend to use resources, because we'll typically do an echocardiogram and other testing to figure out, well, why does this person have this? Why would that occur? We do also one interesting kind of observation, and one of my colleagues, Dr. Marco Perez, is an expert in this area, is for younger patients, people in their 20s and 30s developing arrhythmias that otherwise you should develop when you're 60 or 70. Those are largely genetic abnormalities. We're very early now to direct those patients for genetic testing because that can have great implications for them in their future. There are many different approaches to evaluation and treatment. When we think about treatment, some of it's going to be preventative. The big one is stroke, anticoagulation for atrial fibrillation, stroke prevention. Whenever we see somebody with atrial fibrillation, that's one of the very first things we address. Being in the arrhythmia area, we try to identify your risk. Is it high? Sudden cardiac death, that's another aspect. We want to tailor for the patient the correct treatment plan. Those are the things we think about. Why do they have this? What is the underlying condition? And what is their overall risk? And then we pivot for you. What are we going to do for you in terms of treatment, et cetera? Treatment also has evolved significantly. For some conditions for atrial fibrillation, we're treating people much earlier than previously, particularly large studies that show benefit of earlier treatment of atrial fibrillation. So that could be antiarrhythmic drug therapy, that could be catheter ablation. So these are definitely on the move. For a number of years, we were really heavily symptom driven and didn't consider so much the natural history, et cetera. Now that we have more data about the natural history, that's one area we're focusing on much, much more.
I'd like to focus on your mention of catheter cryoablation, especially as someone who is a co-inventor of the technique. Could you share your insights on when this treatment should be considered and how it compares to other modalities in terms of effectiveness and patient selection?
The journey towards new technologies is an interesting one. For many years, radiofrequency energy was the only real source for catheter ablation. Cryoablation is something that was introduced shortly thereafter. The one big difference is that cryoablation is particularly useful for critical or delicate areas where you're concerned about damage to the structure. As a good example of that, our pediatric colleagues who deal with small patients and patients that have a lifetime ahead, they will overwhelmingly use catheter cryoablation compared to radiofrequency because of the concern that if they have damage, that will result in their whole lifetime of having a consequence of that. That's one of the areas that I think has stood the test of time. That continues to be a go-to technology. In the last 6 to 12 months, there's a new technology called pulse field ablation, which is a new energy source that's very similar to what our bench scientists colleagues use called electroporation, forming little kind of openings in the cell membrane. That has been shown to be a very effective way of treating patients with arrhythmia. That's probably the latest of the shift in terms of technology. I don't doubt that we'll see more advances, though, in that area and a lot more new technology that'll benefit patients.
It's fascinating to hear how technologies like cryoablation and the newer pulse field ablations have evolved and found their place in patient care. It's a great reminder of how innovation continues to shape the field of electrophysiology. Dr. Narayan, this brings me to your work at the Computational Arrhythmia Research Lab. I'd love to hear more about how you integrate interdisciplinary research in this space. Could you share an overview of your current research and how clinicians can apply these insights to improve the management of arrhythmias in their patients?
I'm really privileged to be at Stanford, where we are the hub of so many great things, one of which is computer science. I have a lab which builds between engineering, a little bit of devices and hardware, but mostly computer science, data science, analytics through the data we collect in patients. There's a lot that one can collect. You've got demographics, you've got the ECG, then you can go deeper. How do we put that all together? Recently, we've been very excited about putting these together into AI models. Moving forward, what about if you took that and said, there's this pattern that's really interesting, and it's a certain kind of ECG signal coupled with an electrical signal from this part of the heart in atrial fibrillation, but not this part. You get an even better prediction. Then, okay, this bit is abnormal. Could we actually treat that? Using that as a way to actually guide treatment, not just to predict who will do better and who will do worse. We work increasingly with people in genetics, so I could list a few, but my colleagues Marco Perez and Michael Snyder, just phenomenal people across the med school ecosystem. Engineering, a quick plug for a wonderful bioengineer I work with, Alison Marston, with whom we have a training program. I'm very passionate about blending engineering and medicine, and then everybody across medical school. That's what we try to do with a focus on atrial fibrillation, ventricular arrhythmias, but a bit of everything.
First of all, that's absolutely incredible. I think the work you're doing is amazing. I can't even imagine the scale of data you're working with to create such a comprehensive approach, not just to target and treat patients, but to push beyond current practices and elevate care to the next level. From what you've shared, it sounds like you're leveraging AI models to manage these massive computations and integrate data in a way that drives meaningful insights. How has the integration of AI and large language models impacted the way you conduct your research?
The short answer is enormously, and it's just beginning. On the other hand, it's not that smart in the sense that when a kid is growing up, it'll learn to recognize a train from a car or a book from a car after 5 or 10 times. We have to train our AI models 100,000 times before they can figure that out. A medical student understands an ECG pretty well after a couple of hundred, sinus rhythm, heart block, things like that. And an AI algorithm may need 100,000 or 1,000,000 examples. They're not that smart. But once they are trained, they are unbelievable. The biggest challenge is getting that data. Just as you said, how do we get the right data? And the right data isn't just always more data. More data isn't always better, because if you had 1,000,000 recordings of ECGs with slow heartbeats of 40 and 50, etc., you can't assume that every slow heartbeat is a problem. Some of those people will be athletes. Some of those people will be sleeping. Some of these people are going to be on beta blockers. How do you figure it out? It's all a question of curating that data set right. This is where the field is going, getting exactly the right data sets built that will allow us to answer, will this individual do better from this chemotherapy or not, or this ablation or not?
That's an important nuance for people to understand, highlighting the complexities of utilizing machine learning in research. It's not just a magic solution, but something that requires significant effort and expertise. You touched on this earlier when discussing the intersection of engineering and medicine. I believe you were referring to the Stanford Computational Medicine in the Heart program and its educational goals. Could you share more about this program and how it prepares clinicians for the evolving landscape of electrophysiology?
The program's called CHIP, Computational Medicine in the Heart Integrated Program. I run it with my friend and colleague, Dr. Alison Marston, in mechanical engineering and the School of Medicine. The goal is basically to just bridge this gap between biology, cardiovascular research, medicine, and engineering. This is critical because it's obvious all around us. We're getting more techie. The whole world is. Smartwatches, databases, early warning systems. There's so many things you could think of. Yet people, including myself, get a little intimidated by the methods. What is AI? What's a neural network? We don't all have to be experts. I'm not, but I do understand a bit. And I think if we did, we'd be able to read the papers and really move the field forward. That's the goal. We have a tagline to teach engineers about clinically important questions and to teach physicians how to write Python. You speak the same language.
As we wind down our time together, I'd like to shift the focus to your experiences with patients. In your view, what are the key elements of patient-centered care in the treatment of arrhythmias, and how can clinicians apply these principles to enhance their approach and improve patient outcomes?
I love the concept of patient-centered care, and many times we'll say it's shared decision-making as well. That's engaging the patient and their families. That's where, as we talked about decision-making, many of the factors that we're going to want to help patients with, comorbidities, et cetera, we try to encourage patients not to think that they're coming in for a so-called solution, that they don't really have to change their lifestyle and do other modifications, but rather it's a plan that we're going to come forward together that may have these different ramifications. Certainly, we're going to give them treatment directly for what they have, but we're going to want to work with them to figure out, well, what kind of contributed to this? What could be contributing in the future? It may lead to not as good outcomes in the future. We really want to engage patients and their families in this decision-making process. That can be challenging for patients. Sometimes patients, they come with this idea that just tell me what to do kind of thing. And that's not as beneficial to the patient rather than, yeah, I understand what you're saying. I really absorb the reasoning so I can take that home with me. And then really, hopefully, that'll motivate me towards making these changes. Whereas otherwise, sometimes it just seems very transactional. Oh, do this and okay, I'm done. And they don't really think about what they need to do in terms of their overall health. Hopefully, we try to present a bigger approach to various arrhythmias. We're trying to do that more and more overall at Stanford.
What I heard you emphasizing is the importance of developing tools and treatment plans in true collaboration with patients, ensuring that they have all the information they need to make the best decisions for themselves. It's really about co-creating the plan with them, which is such an empowering approach. Dr. Narayan, how do socioeconomic factors influence patient access to electrophysiology care, and what can clinicians do to mitigate these barriers in their practice?
That's such an important question, and I think we're also well positioned to help. There's disparities in arrhythmia care, like with everything. It goes through the standard triad: less detection, less treatment, and worse outcomes, even when treated. That's true for AF, for stroke prevention, which of course is related to AF, and for ventricular arrhythmias or sudden death. I've been lucky to be on a committee at the American Heart Association. We've just actually put together a position statement on trying to address disparities of care, which is socioeconomic, it's health literacy, it's physical access, but it's also digital things. So many people have smartphones. You can imagine a smartphone app can get everywhere. You don't need to physically leave your job and schlep an hour into clinic. You could do it on a 15-minute break. Algorithms could help diagnose. You could imagine extending this to parts of the world. I'm Indian, so Asia, Africa, all over the world, rural parts of the US. Digital medicine across the board, not just cardiology, arrhythmia, could massively level the playing field. Despite that potential leveling, there is actually a digital divide that's opening. On one hand, these tools could really close that divide and narrow it, provide the evidence base across diverse communities, including underrepresented minorities. On the other hand, it isn't happening yet. Some of it is that an Apple Watch is really expensive, so there's economic. But it's also the resources like the internet isn't widely and uniformly accessible. We wrote this paper with some really notable people who are very interested in the aspect of equity, health equity, digital equity, to try and speak about possible solutions.
Looking ahead, where do you both see the field of electrophysiology heading in the next decade, and what should clinicians be prepared for?
We've seen so much change, it's probably going to slow down or stop, but we're pleasantly surprised that there's a significant amount of change. I'll tell my trainees, for example, if I reflect back on what we did 3 to 5 years ago, I could say every 6 months there's something new that's happened. That's one of the things that we look forward to, as well as reflecting on that in recent years, we've had this explosion of new approaches and different ways and better ways to treat things. We're very optimistic that rate of change will continue. It's a very robust area of development and new arrhythmia treatments. One area that has been a bit slower for the heart rhythm areas is drug therapy. We haven't had a new drug for a number of years, and we're hearing more about that acceleration. There's a lot of areas we need to work in, but I'm very excited about the rate of change.
We're heading into an integrated future where we don't break things down by heart, lung, brain, but in terms of syndromes. Because we'll have wearables, your watch will measure your blood pressure, but also your temperature, and it'll give you a variety of activity. Because of that, there'll be a convergence of the specialties. There's already communication between specialties in disease management and in research that will continue. And because of that, we're going to make headway at the intersections, as we already are: cardio, neuro, cardio, renal, oncology with cardiology. I think that the technology evolution, as we get more comfortable with, it'll become seamless, and that will further blur the distinction. I really welcome patient participation. We have to deal with the work overload, but I really welcome that. And that is likely to continue and improve overall outcomes as well. We won't just be waiting for that clinic visit every 3 to 6 months. There'll be continuous recordings.
You've both been in this field for a while and have witnessed the trends and changes over time. Yet, as I'm speaking with both of you, it's clear that your passion and excitement for this field remain strong. I'm curious, what have you found to be the most rewarding aspects of working in electrophysiology and how this perspective could benefit practicing clinicians?
We're all clinicians. We see the promise of helping patients and fundamentally changing and improving how we treat them. That's really what we're excited about. And as we've seen so much progress, we see the potential, particularly in academic environments. We are very aware of the limitations that we have. So we're certainly aware of the accomplishments and what progress we've made. But at the same time, we're equally aware of the gaps. One of the big gaps I discuss with my colleagues is we don't have enough science going on in our area. One of the reasons we don't have so much drug therapy, for example, we've relied on more mechanical and engineering-based solutions, which are great, but fundamentally we need better drugs to use and other different forms of treatment. Similarly, because a large part of our mission is training, we need to train the best and the brightest and attract them. I think we need to do a better job of that. I feel like the most important thing is human health and how can we improve it. I want the rest of the world to feel the same way. Everybody really wants to work with us and develop new things. That's one of the greatest promises of places like Stanford, where we can bring various people with engineering, computer science together and really do things that really can't be done on our own. And we need collaborators that can do that. That's the exciting part of different places like Stanford that have that capability and have the vision to be able to see what we can do in the future and solve these problems that still are massive. As I mentioned, atrial fibrillation, for example, the rate of increase is astronomical. Patients still die suddenly, hundreds of thousands. We still have yet to make a huge dent. We need to have new strategies. We're working on those all the time. That's one area we are both really passionate about and excited about. We've got a big mountain to climb. We need a lot of help doing that.
It's the patients. It's just fantastic. I've done basic research in my time, and although I loved it, I just wanted to come back to patient care. There's nothing more rewarding than that patient who, at the end of the day, says, "You've really changed my life." It can be as simple as taking away a palpitation, as well as something really dramatic that's life-saving. I also love our environment. I love the fact that we have such incredibly talented trainees coming through who are fun to work with and who keep us on our toes. And I love the fact that it's changing. We're always learning and moving in what I think is a very valuable and worthwhile direction. It's human health, reduction in disease. You can't get much better than that.
Thank you for sharing both the promise and the challenges within this space. It's inspiring to see how these elements continue to motivate individuals like both of you to push boundaries and drive this important work forward. Thank you both for joining me on this podcast episode. It's been an insightful conversation, and I truly appreciate your time and expertise and sharing your perspectives on this important topic.
It was really fun. Thank you, Ruth.
Delightful. Thank you.
This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.